All right. Well, good afternoon, everyone. Appreciate you guys joining. We're very excited. We actually, for those of you who are coming in for a second run, we actually did this webinar about 6 weeks ago and had, now we've got some background noise. Guys, if anybody who's not a presenter could mute their phone, we're going to keep the line open so that if there's any questions, but it's going to require just some folks muting. So thank you. I'm Dana Jacoby. I know most of you guys know me, and I'm very fortunate to have some partners on the call to talk through chronic care management for urology. And what we really realized, even when we did this webinar the first time 6 weeks ago, was just that there was a true need for CCM education around MIPS and what chronic care management could do for our groups. And interestingly enough, and we'll talk through it as I introduce some presenters, but we've actually, even since the first call, had the opportunity to do some real-world case studies and some deeper analytics on chronic care management and what it could mean to our urologic groups. And I'll explain the rationale as to why, but we really are firm believers that this could be something that could be a game changer for a lot of our groups as we move forward into that next foray of just kind of chronic care management, MIPS, and productive future of medicine. So, Paul, if I can get the next slide, we'll go ahead and introduce the concept and a little bit about the presenters on the call. So I addressed some of this, and this slide's a little bit of a build, so you've got to kind of click through the next piece. But one of the things that we looked at on the why behind hosting a webinar on chronic care management is Dr. Koo and Shirley had actually productively researched this at their urology group on the West Coast. And we started realizing that there was a real opportunity based on the market research I was doing in field with different groups, that obviously payment models were top of mind for a lot of our healthcare practice managers and CEOs. And for a lot of our groups, ancillary revenues are either down or flat, and they're concerned about macro and MIPS. I mean, and I know for any of you who've been to urology conferences this year, I stopped counting how many times macro was on the agenda just because it was something that we were all being tasked with. But the reality was, due to the nature of the fact that we're a small specialty and also the fact that there was a lot of the following the bouncing ball on the macro solutions, there just weren't a lot of tactical tools to really help our groups move the needle forward. And so we started really doing macro and MIPS webinars earlier this year, and everyone that we put on the schedule, and honestly, we just kind of did it on our own accord. There was no real, governing body that said to do it. There was no funding for it. We just decided for educational purposes it was the right thing to do. And we had constant folks saying, thank you so much. We didn't have any real education behind this that was specific towards urology. More importantly, there weren't any toolkits or resources that were helping around the education of these types of solutions and how to offset, revenue degradation and or create new ancillary services revenue for our groups. And most of us know, but it goes without saying, I'm preaching kind of to the choir, as they proverbially say, but, a lot of our groups have run in somewhat a siloed approach to care. And we don't do a great job of treating chronic conditions. And I think the more that we embrace and develop tools like chronic care management and the education behind it, it just really helps us to focus our groups more on the chronic care continuum, and also to really look at how to create additional revenues for our groups, and more critically, how to really treat the patient from start to finish, whether it's OAB or BPH or even, prostate cancer patients. The reality is most of our conditions that we treat in our urology groups are chronic in nature. And so anything where we can recognize additional revenue or reimbursement underneath that guidance, we felt like would be a productive reason to put a webinar and education on these types of engagements and calls. So I'll go to the next slide, Paula. So I somewhat introduced myself. I'm very fortunate to have two partners on here. Everybody is probably familiar with Skyline and Dr. Alec Koo. Alec has been a tremendous partner in developing these types of resources, always an innovative thinker, is on the LUGPA board and has truly been a driver, for new things urology, not just as a pilot underneath his group umbrella, but also within LUGPA and across urology groups nationwide. And this was something that he and I actually started looking at 2 years ago, actually, chronic care management, and came across it on a weekend on a complete research mission for something else. and thought, gosh, wouldn't it be cool if we could do this for urology, and fast forwarded it and piloted it and built some really good tools and resources, and then quickly realized that we were onto something that we thought could be helpful for most of our groups as they move forward. In conjunction with ALEC, we're very lucky to have a partner in Shirley Lee. Shirley is the president of Arete Medical Solutions. Not only is she a healthcare consultant, she has a very, very deep clinical background with a Master of Science degree in nursing, and she's a nurse practitioner by background. You know, whereas you've got kind of the market research and operations arm with me, the clinical medical director arm and vision with ALEC, Shirley really is that frontline care model person that also has a very detailed lens and truly has become the preeminent expert in chronic care management. And you'll quickly learn as we kind of go through this call that her company is really the one that has been a tremendous help in operationalizing some of these tools and resources on site at groups moving forward. We'll talk a little bit about the dive through and crossover. So we're very fortunate to have an expert panel.
So, hey guys, this is Alec. Know a lot of you on the line, so really, really good to be amongst friends. So we'll start off. We'll kick this off. Just if everything's about value-based payment these days, and we all know value-based payment is coming. And no one really knows what exactly it'll look like in our own neighborhood. What we do know is that there are key tenets of value-based care, which includes care coordination and navigation. And now a lot of large urology groups are currently have navigation in advanced prostate cancer centers and overactive bladder navigation and performing care coordination. You know, with the conundrum is that we are not in value-based payment systems yet, but yet we are tasked to start providing the structure for it, which is care coordination. And there really is no pay for, there is no reimbursement for this until CMS with CCM generated a code that will provide for payments for care coordination and care management. Next slide, please. So the code actually was rolled out about 2 years ago, and the code is 99490. And it specifically pays for non-face-to-face care. And so non-face-to-face is broadly defined as anything that you do on behalf of the patient. So if you actually call the patient, staff calling the patient, or staff calling the pharmacy, provider calling the patient, or the provider speak to another physician, they all count. And these are actually the type of services that traditionally we have always provided. And yes, they're care coordination. But the care coordination that CMS is thinking of is really more in terms of navigation and care plan. And this really goes back to the concept of value. And because care coordination really underpins value. So a quick example is, for instance, when a patient is discharged from the hospital. So that calls into transitional care management. And so very simple tasks, such as the care coordinator reaching out to the patient's family, making sure that the medication as prescribed on discharge is reconciled with what the patient already has at home, that the patient knows what medications to take, and just that alone probably will drive for quality because the patient is in fact on the medication that they're prescribed, and which often can be a very confusing situation. And by taking the right medication, it reduced the likelihood and risk of them getting readmitted to the hospital or visiting the ER. And other care coordination, such as just making sure once the patient is discharged that they see they're able to get an appointment to see their regular physicians. All of these things mitigate risk. And so care coordination is really is designed to fill the gaps in the current healthcare delivery system. And so this is really what CMS has in mind, and this is really what they would really like to pay for. And CCM is really the initial effort. Next slide, please. So CCM, like all CPT codes that CMS has a very specific set of rules that providers, if wanting to bill for it, must follow. The rules for CCM is more structured and is multifold compared to your typical CPT code. The patient must have at least 2 chronic conditions. And CMS has a list of 12 chronic conditions that they publish, which changes from time to time. Initially, 2 years ago, it actually included BPH. If you look at their website now, it's no longer there. But it doesn't mean that they don't consider a chronic condition. In fact, it's specified on their website as that the chronic conditions are not limited to these. Just like all CPT codes, it takes a while for the codes to be enacted and implemented by the various contractors for CMS in different regions. So Skyline, a couple of years ago, what we did was that we provided services, tested billing, and we understood that at that time, BPH and prostate cancer were chronic conditions that our local contractor considered payable, whereas OAB diagnoses were not. We test billed incontinence, urgency, they were not paid for. And whereas this year we test billed several months ago, and it appears that some of the OAB conditions now are covered and are considered chronic conditions. And what is really considered a chronic condition and billable obviously varies by the Medicare contractor in your local region. So that's one caveat, and before any group embarks upon this, that's one area that needs to be fleshed out, and Shirley will speak to later in this talk a little bit more details on how to go about that. And what they pay for is 20 minutes documented of non-face-to-face time. And the code pays, in general, $42.60 and needs to be adjusted for region. So here in Southern California, it actually pays $48 and change. And some of the other requirement is that the service could be provided by anyone in the urologist physician's office, as long as the personnel is supervised directly by the physician. So it could be my medical assistant, as long as he or she is under my direct supervision. You have to use the certified EHR. The team, your entire team who might be on call for the patient, needs to have 24/7 access to the care plan and the EHR. A lot of these are somewhat routine stuff that we know, but there's also a consent. So the patient needs to be specifically consented, that the patient needs to sign a consent, understand that their physician, your group, will actually be billing for this code. And there needs to be a care plan for the patient's chronic conditions, and it needs to be an electronic one as opposed to a paper one, because they would like this care plan to be 24/7 accessible by the care team. Next slide. There's some misconceptions out there. The code, when it was rolled out initially, was intended primarily for primary care physician, but it was clearly stated that specialist physicians were also allowed to bill. It's for Medicare fee-for-service patients, not for Medicare Advantage patients. Now, there is a temptation, obviously, because we already, in our office already, provide non-face-to-face care to patients, to just use this code to pay for phone calls and calling the pharmacy, getting authorizations. But it's actually in alignment with the spirit of the code. It really should be used for care coordination and care navigation, which most of the large urology groups are, in fact, attempting to do. And so it's, I think it's optimal to identify a specific set of urology patients. And the classic group will be, for instance, the patients that we create our Advanced Prostate Cancer Center around, starting with the Bone Health Clinic and progressing to advanced cancer patients. we would probably start with all patients who are on androgen deprivation therapy. And if there were a navigation team for this, it's a perfect setup whereby the CCM code would actually be part of the workflow, obtaining consent and then documenting navigation time and using that documentation and the service provided, care coordination service provided, to bill for the code. Some of the other obvious urology population would, that may qualify for this, now that we believe they're starting to reimburse or consider overactive bladder conditions as chronic conditions that are billable, would be an OEB navigation team. But there could be other groups, bladder cancer patients who is receiving BCG, and there may be a higher level of care just to mitigate any side effects and UTI. So I think it's the approach really is to have a systemized approach, and then this code could be used to help urology group provide the infrastructure for care coordination and navigation. Next slide, please. Next slide, Paula. The simple case example of how this could be implemented and what the financial implications are. 2 years ago, our group, when we were looking at this, we ran our data. We had around 500 Medicare patients who are on androgen deprivation therapy. We were in process to generate a registry for these patients. And so these patients, if we were to put them on the CCM program, in Los Angeles, they were paid approximately $48 per patient per month. So that gives us approximately $24,000 of anticipated CCM revenue stream. And over a 1-year span, it's almost $290,000, $300,000 of budget. And so we could budget out the anticipated revenue, and we use that to hire additional navigators as well as software to support the navigation. And because we are anticipating a regular monthly income, we're able to use that budget and plan it out and supercharge our navigation system. And so in this way, we're able to have the budget, run a better prospective ADT registry navigation, which ultimately led to much better patient identification as well as patient care in a true care coordination fashion. I'm going to turn the mic over to Shirley Lee, and Shirley will go over some of the details, as she was really the nurse practitioner MPH in our practice who implemented the service. Shirley?
Yes, hi. Thank you, Alec and Dana. This is Shirley Lee over at the Medical Solutions. And I just want to say it's been such a pleasure partnering with Dana and Alec, who have extensive experience and passion in partnering as we're pushing the needle forward and advancing urologic care, not just patient by patient, but really on a broader programmatic model level. And as a clinician, I have to say it feels really good to see, certain things that could be done on a programmatic model level, and then actually be able to build it out and get it done. So what we have done is, for the last 2 years, we have implemented the chronic care management program, and we wanted to put together a playbook that would allow everyone to use all the tools that we have developed, because quite frankly, it takes a lot of time, a lot of effort, a lot of detailed editing to ensure that you're providing the service not just in a programmatically correct way, but also in a way where we're getting billed and where we're billing and we are getting reimbursed properly. And then, of course, most importantly, that patient care is being advanced. And, that's why we all get into healthcare anyway. I want to take a very quick step backwards and just say, why are we doing this anyway? This is the chronic care management. Medicare has really marketed it more towards things like diabetes and hypertension, things that we're used to thinking of as chronic care. And, how has that made a difference as we have implemented the chronic care management program within a urology practice? And to me, the best way to answer that question is to think about some patient lives that we have affected. And so I have a couple examples here of just ways that patients have told us that their lives have been affected because we've now developed this infrastructure where patient navigators are calling them and are following up with them, and therefore have this additional net of support for them. So for instance, we had one patient who said that they needed to schedule a kidney biopsy. When they were called to follow up on how that was going, they had given up. They had called one hospital and basically were sent to 5 different lines, and nobody had the right answer, and the patient was just fed up and stopped trying. So our patient navigator, said, okay, let me figure this out for you. Indeed, when they went ahead and did it, they came against the same obstacles, but were able to, get through those obstacles and allow that patient to go ahead and schedule their biopsy. So, it's things like these that we don't necessarily always know that patients are having trouble with things unless we ask them, unless we're in touch with them on a regular basis and say, what obstacles to care do you have right now? Well, maybe in layman terms, how can we help you? And, and then really help them to just get through these obstacles so they don't, I mean, who knows what would have happened to this patient had they not gotten their kidney biopsy. We have patients who call us because now our patient navigators are calling more regularly, and so now they know, okay, here is an advocate in my corner who I can call them and get a direct line, direct access, and someone will pick up the phone and know what to do. If they don't have the answer, they'll find that answer for me. So now we have patients who call because, it's a patient's son who's actually the caretaker, and they're calling because the father has fallen and he has no idea why, and he was found because the environmental services people, the people picking up their trash, noticed him on the side of his house. So the patient navigator is the one who says, okay, let's call your primary care provider, let's get you, into urgent care, make sure you are scanned, and basically just hold their hand through that process. So I'm giving you some examples of things that are not exactly directly the chronic care management, the program that we've provided, which I'll go into detail shortly. But I want to tell you this because this is what's important. Our patient navigators they are actually saving patients' lives because we've now developed this care coordination infrastructure. So thank you, Paula. So this is what our playbook is composed of. We've thought of 5 different main components that we need in order to, 1, assess if a urology practice should go ahead and implement the CCM in their practice. So that's the first one, is the profit assessment, or your return on investment calculator. The second is operational protocols. Any practice administrator, cancer center director on this call, even just, any program administrator here knows that just saying, hey, let's start billing for this is not as easy as it sounds. If we're going to now change operations, we need to really communicate within our team, front office, back office, billers, providers. Everyone needs to understand what we're doing, and everyone also needs essentially a little cheat sheet to remember what it is that they're doing just for this code or this program. The third thing is clinic visit templates. As a clinician, I know what I need to ask each patient. But if you put it into an EMR template for me, bam, 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 I know I've addressed all the main things. Great, move on. We've got 15 minutes. I've hit all the main important points. And, you know, very importantly, number 4 is the EHR templates are there to ensure Medicare compliance. So we'll talk a little bit about that. And lastly, patient education. If your patients have not bought into this, if they don't understand the value of this program, it may flop. And so that's why it's so very important from the very beginning to educate your patient about what is this? What is a chronic care management? You know, what is it going to cost me? What are, you know, addressed all of their concerns, and we've created some tools to address those from the beginning through the end. Next slide, Paula. So the profit assessment ROI calculator, basically you input your regional code reimbursements, your staffing rates, like let's say you know, everyone may have a different rate per medical assistant, your various billing rates, and also, unlike other programs or softwares you may have seen, you know, ours is based off of what we did in a urology practice. So that means we're really incorporating things like room availabilities, you know, how much time is spent per patient per visit, and is it even realistic because you only have X number of rooms and therefore you can only spend X, you know, Y amount of time. And so all of that is incorporated into the expense portion. And basically your ROI calculator reads similar to any other P&L you might see, and you'll get your net profit at the bottom. As Alec mentioned, really the potential for additional revenue is quite significant. You know, otherwise we wouldn't continue doing it today and we wouldn't be talking about it now, but it's very, very helpful, I think, to personalize this and say, well, in my region, you know, with my staff, with my medical assistant or my nurse practitioner and PA, these are the things that these are the rates we use, you know, how would it affect the bottom line? Next slide. So Medicare started this in 2015. It's now been 2+ years, and since 2017, starting January 1st, they got so much feedback about kind of the how much additional administrative burden there was for this program. They went ahead and made it easier for us. So on one end, they increased reimbursement. In 2016, you have $42 for your average payment. In 2017, you have the potential for about $141 per patient, depending on the complexity of how much care coordination they need. On the administrative burden side, the initial visit, initially they had said everyone needs an E&M visit, basically a very comprehensive visit to cover all of their chronic care conditions. Now Medicare is saying we don't need that if you've seen the patient within 1 year. Well, how likely is it that you've seen your chronic care patient within a year? Your patient with prostate cancer, bladder cancer, OAB, you've probably seen them within a year. So really, you know, for most patients, that means they don't need an additional E&M, which is great. The care plan does need to be communicated to other healthcare providers. This makes sense. You know, if we've changed the patient's care, we should communicate it. What they've said is that initially that had to be electronically communicated, which is a challenge because not all providers have HIPAA approved emails. They should, obviously, but you just never know for sure. So now they're saying it's acceptable to send it via fax, which is another great thing to not have to worry about. One other thing Medicare did in 2017 is, Alec mentioned the consent. The consent now does not have to be electronic. It doesn't have to be a form. It doesn't have to be written. It can be completely verbal. Of course, it does need to be documented in the electronic health record, but it can be verbal, meaning your medical assistant could speak to them over the phone, get the verbal consent, and then document in the EHR that they did consent. Next slide. So I mentioned operational protocols. This is the second piece of our CCM playbook, and it has the workflow, it has job descriptions, job duties, billing protocol. All of the program administrators on this call will love to hear that we have all of these included in the playbook. And I'll just show you in the next slides a couple of these examples. So next slide, Paula. Here we have job duties. So basically, you'll see that if you have an initial visit for the patient, as I mentioned, most patients are not going to need that. In that first row, you'll see what the medical assistant does, the biller does, the NPPA does, and what the physician does. And the next row is the care coordination. So monthly, what that means is 20 minutes are spent coordinating care for that patient. It could be, 10 minutes at the beginning of the month, another 10 minutes at the end of the month. It could include, reviewing the patient's chart and calling the patient as needed, maybe calling the pharmacy, maybe calling their, like that patient mentioned in the beginning, calling to help them schedule their kidney biopsy. Unfortunately, there are times that something like that does take 20 minutes, and then you're done for that patient in terms of, meeting that minimum billing requirement. And then you see what the biller does for that monthly care coordination. The NP&PA and the physician, you'll notice that really they're there as resources to respond to questions, and the NPPA can be your first line of resources to answer questions from your MA, and they can provide a comprehensive E&M visit as needed, but again, that's not needed for most patients. Your physician, you'll see, really is just there kind of on call. You are, of course, reviewing, that the MA and the NPPA are just acting in according to what you would like them to do. But the beauty of all that is, in the next slides, we'll talk about the clinical templates that we've created. And essentially what that is your clinical pathway that you would like for, your MA or your NPPA to follow are already embedded into those templates. So you shouldn't really have any questions as to, how did they respond to this? Once there's some sort of red flag, patient had, something concerning, blood in the urine, oh, great, they did get them in, for a same-day visit, that kind of thing. Next slide. So this is the workflow, and what this image shows us is basically at the bottom you'll see 9 different pieces of the CCM playbook, the operational protocols piece of it. And this is the patient's experience. From the first box, the patient sees an NPPA if they haven't been seen within 1 year, and you would use 1, 2, 3, all those 3 things. You would use that Intro to CCM patient handout, you'd use an initial visit template that's already in your EMR, and you'd use the billing protocol at that step. The next step, patient signs informed consent. This does say sign, but of course can't just be verbal. And for auditing purposes, if anyone has ever tried to dig into your EMR to find anything that's not already flagged as something separate, i.e. CCM, informed consent, it's going to be extremely hard to find. So we do encourage that even though you get the verbal consent, the patient signs it and you flag it as a CCM informed consent, just in case someone were to come audit, you know where to find it, and you have it written in a very standardized and easy to find format. And then every month, the patient has their care coordinated, and through that you'd use a phone script that the certified medical assistants or just medical assistants would use to introduce the program, Of course, they can use their own language and make it more natural for them, but we have the scripts so they don't have to think of, how to talk about the whole program to patients. We have the care coordination visit template, the care plan templates. 7, 8, and 9 are basically different forms and things that you would use after you've provided that care. You provided the care, now you need the care plan. And then now you need the letter to their primary care provider. You need to hand them a visit summary, and you do need a termination form in case the patient elects to terminate the program. Next slide. So as I mentioned earlier, from a clinician standpoint, you do want to make sure that anyone in the office is, caring for your patients in a way that you would like them to. And most importantly, if there are any kind of red flags clinically, that they note that, they know it, and they know how to respond to that. So we've built those into the initial visit template as well as the care coordination template. So you have a lot of non-face-to-face coordination happening, and a lot of that could be over the phone, and you want to make sure that they're providing really safe care. And so, as I mentioned earlier, there are red flags for certain answers, and then there are specific directions. Okay, call 911 for this patient, get this patient in to see the provider right away. If it's within this range, speak to the NPPA, that kind of thing. So we have it very, very detailed, disease state specific templates. So that means if you have, a patient with prostate cancer, as clinicians, we know that if it's a newly diagnosed patient versus a patient on ADT, you're going to be asking completely different questions. You're going to be, following up with them very differently. And so your MAs are instructed in a very clear template. Ask these questions for patients who are newly diagnosed. Ask these questions for patients who have been on ADT. Ask these questions for patients who are CRPC. So not just disease specific, but also disease state specific, which, as clinicians, we know is extremely important. Next slide. So here is an example of the care coordination template that goes into your EHR. For anyone who's ever created an EHR template, you have a patient with prostate cancer on ADT, you want to ask the same questions to most of these patients, and you know that the easiest thing is to have answers pre-populated that you just click, and you do not have to write the same paragraph over and over and over again. So the same for, these are, the same for your MAs. They don't want to have to, you don't want them to spend time, trying to remember what it is they're supposed to ask. So it's all here. You literally take these templates and you hand them to your EHR super user or your vendor, and you're all set. So basically you have EHR question is, what's your chief complaint? And the options are hot flashes, fatigue, decreased libido, etc. The pros is on the visit summary and the care plan template, it will spit out patient's chief complaint is, and then whatever you selected, and the EHR backend tells you, this patient has prostate cancer, so make sure that that ICD-10 is basically automatically put into the bill for that day. Next slide. So the EHR blueprint for Medicare compliance basically shows us that, we have a defined set of questions and answers which inform all of your CCM implementation, everything from data inputs to data outputs, and then all of the requirements that Medicare has for CCM implementation. They require a care plan, they require you to send that to the PCP, and they require visit summary templates. So you'll see that once you've inputted everything, it just auto-populates into those templates. Next slide. And this is one of them. So initially, basically, you'll see, the patient's name, date of birth, MRN, their problem list, allergies, medications. These are all things that Medicare is requiring for compliance, so we've made sure to include all of those things. Other things we've included: advanced care planning, care transitions, medication reconciliation. And so it's important to note that it's not a 20-minute phone call each month. If you're calling somebody once a month, maybe month one you're asking, did you go to the urgent care or ER? And if so, we should definitely do some medication reconciliation, because that's when we know a lot of patients have their medications changed and therefore could really affect their care. Month two, maybe you're asking about advanced care planning, so it's not that you have a very super long list to go through each time you call them, but you have all these options and things that you could address each time you call, or maybe it's not even going to require a phone call because, you've spent enough time on the back end coordinating their care. Next slide. And this is an example of the informed consent that we mentioned earlier. Other patient education pieces we've developed are a patient-friendly handout in very layman terms, what they care about hearing. How much does this cost me? Who's going to call me? Do I need, things like that are all addressed in that handout. And the phone script, consent form, and termination form. Next slide. So as Dana mentioned in the beginning, we've all heard a lot and too much and sometimes not enough from Medicare about MACRA and MIPS. And CCM and MIPS actually have quite a bit of synergies. These 5 different bullet points were pulled directly from the QPP website, discussing, for improving activities, what, there's a super long list of things that you can do to prove that you have fulfilled that piece of MIPS. And 5 of these are automatically checked off and done if you are implementing CCM. It talks about chronic care, talks about care coordination activities. So it really is just different words for the same thing. As long as you've documented your work in your EHR with CCM, you've also fulfilled your MIPS improvement activities. Next slide. So in summary, it's very exciting because it really is the first non-face-to-face care coordination that is reimbursable from Medicare. And so we can utilize the fact that they are now reimbursing to go ahead and build the infrastructure needed for patients. And, the urology practice actually does have a significant percentage of their patients eligible for CCM. And then, as I just mentioned, there's that potential to satisfy your key improvement activities requirement. Next slide. And now I believe I'm going to pass it over to Dana.
Yeah, thanks, Shirley, and thanks for your participation, everybody. As you can probably hear from Alec and Shirley's discussion, we've put a lot of time and energy into kind of the development, not only of the presentation, hopefully the presentation was valuable for everyone, but also into the playbook that was discussed, and really just really making sure that we could help groups operationalize this. And we really thought long and hard about how to parlay all of the hard work and energy into providing this tool or resource to our groups, and decided it would make a lot of sense to offer it online. Obviously, the education totally for free. We're here as a resource, as you guys always know. And then the tool book, there was so much energy and effort that went into it with all the resources and tools that the 3 of us just decided it would make a lot of sense, rather than trying to do it group by group by group nationwide, to just offer it online as a possible resource for groups to purchase if they so chose moving forward. As an aside, and just something that it has been, again, interesting, being that this is the 2nd presentation that we've done on this, we did have some groups that went ahead and purchased the playbook and have, 1, been able to implement the solution, but 2, Shirley and I are available as a part of the discussion to really help with any back-end questions you might have on the heels of the webinar, with anything related to the tools, resources, or playbook. So we definitely want this to be a continuing education rather than just a one and done. And then the other thing that we're very much committed to, just because between the macro and MIPS webinars and this webinar, we've just heard nothing but resounding, yes, we need more of that type of thing for urology. We're going to continue the educational effort with additional topics. So if you have any topics on the heels of this that you feel would be beneficial for the specialty, we are all ears. And so far we're putting together some very productive resources for different ancillaries, as well as for new therapeutic indications that are coming into our specialty, i.e. bladder cancer and some of the BPH initiatives moving forward. So the link is here. We'll also email, just so everybody knows, as a back end, we will email the complete recording to the webinar, so you can listen to it again if you so chose or so choose, and then also some additional follow-up materials that you'll have on the heels of today's session. Next slide, Paula. So if there's any questions on the heels of this, please let us know. If not, we definitely want to be respectful of folks' times, being knowledgeable that it's late on the East Coast and getting late as we move across the country. But if not, like I said, we've had some very productive Q&A on the back end. We're all available via email or cell. If you guys know our contact information, definitely can also go to the website that's mentioned here along with my website if you need to get in touch with anybody live. But if there's any initial questions, we've got a few minutes. We're happy to take those. And if not, we can go ahead and close out the session and wish everybody a good evening.
Hi, Dana. There's one. I was going to say there was one question in the chat. I just wanted to speak it out again to make sure that it was answered. Tim Erickson had asked earlier.
Yeah, I'll address that. Yeah. So.
Okay, you got it.
Yeah. So the question, if everybody looks at the chat section, is that, what is the expected population urology practice that have 2 or more urology-related chronic conditions? And can you only do CCM for urology-related chronic conditions and not non-urology conditions? So BPH is still one of the chronic conditions, and any cancer other than a skin cancer is a chronic condition. So strictly speaking, any man who has prostate cancer, who's not had a radical prostatectomy, has 2 chronic conditions already. So it's really kind of, with that basis that we can initiate the androgen deprivation therapy group. But easily you could include in non-urologic conditions. The question is always, the legitimacy of a urology group managing 2 chronic conditions. It's probably inappropriate, although it's not strictly disallowed, for urology groups to be managing hypertension and diabetes. But I think in the spirit of the code and care coordination, there are going to be patients who are general medical patients with diabetes, hypertension, that really are better left to internal medicine or general primary care practice groups. But I think when patients develop certain urologic conditions, especially prostate cancer, or they're on ADT, or they have bladder cancer, or their OAB is really their significant illness that's being treated at the time, and those are the times that obviously urology, the specialty, should take the principal role in care coordination. So I don't know, Paula, if you want to do the Q&A just by opening up mics, or do you just is it better?
Everyone's mics are open at this point. So if you have a question, you're welcome to either type it into the chat or to just jump right in, because everyone should be unmuted.
And if there aren't any questions, I was going to say, if there aren't any questions, because we, the beauty of having a second webinar is we had a similar situation the first go round, and then on the heels of this, it is a lot to digest, I think, in one sitting. This is 2 years worth of research and tools and resources in 1 hour. So, please, if there's any questions, and hopefully you guys know, Dr. Koo and myself and Shirley well enough, we're available for follow-ups and/or for any additional thoughts you have regarding the toolkits and/or additional topics moving forward. So if there's nothing else this afternoon, we'll go ahead and close out the webinar. And as always, really appreciate everybody jumping on. And I know it takes time to sit in for any kind of CME or continuing education types of events. And we're committed to definitely making sure that these types of engagements and educations are available for the specialty moving forward. So have a great evening, and thanks for